Hello, welcome to a discussion about the future of healthcare quality. I'm Andy Reynolds with NCQA. Today's webinar starts with remarks from some of the leaders you see listed on your screen. We'll go to a brief discussion between panelists. Then we'll open things up for Q&A. We encourage you to submit questions anytime during the program. To send us a question that you'd like us to answer during the Q&A, please use the Q&A button at the bottom of your screen. In the next 24 hours, NCQA will send you an email with 3 things that you'll want. First, the slides that you're about to see. That email will also include a recording of today's session. Also, that email will include a survey that we ask you to complete. We'd like to hear what you thought of today's event and use the survey to let us know what you might want to hear more about in the future. At this point, I'd like to turn things over to our event moderator. He is NCQA's Vice President for Public Policy and External Relations, Frank Micciche. Frank, over to you.
Thanks, Andy, and thanks to everyone for joining us. We're excited to share with all of you the recommendations NCQA has made to the Biden administration around some of the core issues we see as essential in order to create a more equitable, sustainable, and efficient healthcare system. In a minute, you'll hear from our president, Peggy O'Kane, about the challenges and opportunities in healthcare that NCQA sees in the next 4 years and beyond. Following Peggy's remarks, NCQA's Dr. Michael Barr, who runs our Quality Measurement and Research Group, our Chief Product Officer, Brad Ryan, and Peggy will provide a quick summary of the proposals contained in the memo. After that, we'll be joined by Dan Mendelson, the founder of Avalere Health, and someone with a vast array of experiences in both healthcare and presidential transitions. We'll get Dan's perspective on the #1 healthcare issue of the moment, combating COVID, and on what we can expect from the new administration and Congress in terms of healthcare policy. Before I hand off to Peggy, let me say a few words about what this document is and what we intended it to do. This is, in many ways, a distillation of hundreds of conversations, meetings, and working sessions, internal and external, through which NCQA has developed our perspective on where healthcare and healthcare quality in particular must go during the Biden administration. It highlights where we see the potential for improvement and what principles and themes should guide the effort. It then provides some specific thoughts on how we might get there. There are big ideas in here that challenge how things are done in healthcare, including how NCQA operates. None of it is meant as a criticism of current practices, but a vision for how things could be. Since we released the report last month, we've received plenty of feedback and questions, most positive and constructive. If NCQA, among many others, has helped elevate these crucial issues, we're grateful to have had the chance to do so. More importantly, we hope this will be a chance to start or continue the work we've done with many of you and the Biden administration on how to do better by the clinicians, plans, systems, and most importantly, the patients whose care we measure and work to drive improvement in. Thanks again for joining us, and now it's my pleasure to hand off to NCQA's founder and president, Peggy O'Kane.
Thank you, Frank. So can I go to the next slide, please? So we're going to focus today on some important themes that underlay what we recommended. And I think one of the wonderful things about doing the work that we do, and especially for me that's been there from the beginning of the work, is you're learning constantly, and it's a very dynamic environment. Sometimes you're learning hard lessons, and I would say that health equity is something that we've been working on for a while, but I think the COVID experience has showed us that we have to work harder and we have to focus more on closing these gaps. We're talking about gaps in chronic illness treatment and so forth that really actually made people way more vulnerable to the really bad cases of COVID. So we have been tuning up the work that we've been at for a long time to really make sure we can be effective. And what's very exciting about this time is I think that there is a shared sense of wanting to commit to something that really works. And we see that with employers that we've been talking to, with Medicaid programs, and we know we're hearing a lot about Medicare's commitment as well. So it's an opportunity for all of us to kind of create synergy, and that's what's really needed to move quality on this particular set of issues. I think the second theme is that we really have too much burden, too much avoidable burden in the way that the quality measurement system currently works. Some of that is due to lack of alignment. Some of it is due to the way data are currently shared and used. So, you know, there are multiple causes. Some of it's due to workflow issues. So it has taken us to an important point about rethinking the role of quality measurement, and you'll be hearing more about that from Brad in a few minutes. And then as we're using value-based models, as we're trying to create rewards and align the incentives for value, we want to make sure that people are operating with data they can trust. And we're proud of NCQA's pioneering role in making sure that the data that are used for quality are trustworthy. And so we've been working on that for a long time, and we'll have some more to say about that. So these are really kind of very important things. I would say that we are also at a moment of really incredible opportunity because COVID, a silver lining of COVID is it pushed healthcare forward using new technology and so forth in ways that we really shouldn't squander the opportunity. There are lots of things that can be done differently to get more quality, affordable healthcare. And so it's a moment of, you know, it's been a terribly difficult moment. We're still in it, but we can also see the opportunities that present themselves. Next. Next slide. Yeah. So, you know, we want to make sure that, you know, quality measures don't mean anything if you can't compare and benchmark, right? So in order to know what good is, you need to see a distribution. We want to make sure we're measuring things that matter, and process measures matter a lot when they lead to really, you know, real important improved outcomes. And so we're strong defenders of process measurement as long as they are driving very important outcomes. We want valid and reliable data. I just talked about that. We want it to be actionable, and sometimes, you know, actionable can be in the eye of the beholder. There are some things where it's obvious what has to be done, you know. So if someone has just been diagnosed with hypertension, we have an array of drugs that can be used. If someone is obese, we know what to do. It's not necessarily always going to work, but there is an action that can be taken, and it needs to be timely. So that's one of the frustrations of the current way that quality measurement works, is people find out after the fact how they did, and not at the time of delivering care. And I'm hoping that Brad is going to say a couple of words about that. We want to be driving toward the outcomes we want. And when I say outcomes, I mean the patient's health, the health of the country, and also the affordability. It needs to be patient-centered, so no one size fits all when it comes to quality. And so I'd like to know that whoever is taking care of me knows about me and knows what my issues are, and has a care plan that's really designed for me. And we want it to be digital. We've spent a lot of money in this country to get to a place where we have loads of quality data, and we are not using it to its full advantage. And so that is a big goal, and we are very committed to working with the rest of the healthcare community and the government to make us get our money's worth out of all that investment and hard work. Next. And this is Michael. Oh, no, this is me. Excuse me. So we want a healthcare system that is enabled, resourced, and effectively engaged in promoting health equity and holding stakeholders accountable for doing so. So we know this is complicated because not every cause of the inequity in healthcare is caused by healthcare. But as with everything else, the healthcare system needs to meet the patient where they are and to help the patient deal with what they have to deal with. We know that there are lots of externalities that affect the health of patients, but the healthcare system can be part of the solution. And there's been a lot of really important research and understanding that's been growing from the experiences of people at the front lines of delivering care and from health plans about how to get better outcomes, even when the causes are beyond the healthcare system. And so Michael is going to talk to us more about that.
Thank you, Peggy. So that was the vision. And let me just get into some details from the proposal on the report.
It's the next slide, please.
Actually, we could hold on that slide.
Oh,
Sorry.
okay, I'm sorry.
For 30 years, NCQA has been committed to quality care. And quality care is or should be equitable care. Unfortunately, as Peggy has alluded to and described, disparities in equity can continue. And differences persist among specific population groups and their ability to attain their full health potential. We can measure this in terms of incidence, prevalence, mortality, burden of disease, and other adverse health conditions. But this is about people, their lives, and the failure over and over again to advance health equity. The pandemic is just the latest example. You see disparities in access to care, outcomes, and vaccinations. Please advance to the next slide. Given the events of 2020, NCQA has recommitted to advancing health equity. We are engaged in an organization-wide effort to bring this commitment to the forefront of our products, research, and measure strategies. We believe NCQA can play a significant role based upon our recognized history in developing standards, defining data necessary in this case to identify disparities, measure outcomes, and enable positive change. Some of our programs already require understanding social determinants of health, demographic data collection, and provision of culturally and linguistically appropriate care. And we are currently in the process of introducing race and ethnicity stratifications into HEDIS. And by the way, we have a public comment period opening up this Thursday at 9 o'clock, February 11th, and that will remain open until March 11th. And we welcome your comments on some of these proposals. A key challenge is that there's been limited and inconsistent progress in the collection and reporting of data stratified along race, ethnicity, and other characteristics. These data are necessary to help support policy development and create the transparency necessary to implement appropriate interventions and advancement of equity through measures. Now, most Medicaid and commercial health plans do not consistently collect or report race or ethnicity data on their membership. It can be done, though. Medicare Advantage plans have demonstrated that doing so is feasible. Over 80% of MA plans have complete or partially complete race data. 35 state Medicaid agencies require managed care organizations to address health equity and social determinants of health in some way. However, it remains clear that there aren't any nationally accepted, validated, and feasible standards or common performance measures to guide health equity efforts. States such as Pennsylvania have shown promising results at the community level using programs such as NCQA's multicultural healthcare distinction to promote collection of data by health plans and work with healthcare systems to address disparities in care. A standardized framework is desperately needed, and it should promote cross-sector collaboration and efforts to address health inequities through value-based payment arrangements. And there's strong interest from CMS, states, and health plans to do just that. We are working to identify and test standards that assess whether health plans have the structures in place to help mitigate social risks and meet beneficiary needs. And our performance measurement team is identifying and testing methods for assessing equity outcomes, such as developing benchmarks for existing performance measures and examining approaches for using community-level outcomes to evaluate and incentivize health plan performance. We look forward to working with the Biden-Harris administration and many of you to achieve a better, more equitable healthcare system. And we look forward to your input through the public comment period, again, that opens on Thursday, February 11th at 9 o'clock. Thank you very much. believe Dr. Brad Ryan's next.
Thank you, Michael. I'm going to speak a little bit about digital quality measurement, the second major point that Peggy teed up, and some of our recommendations to the new administration around how they can think about, and more importantly, help accelerate and drive some of the transition towards digital quality and the benefits that we believe that can provide. So as Peggy mentioned, some of the challenges of the current system are well known and often spoken about. It's labor and resource intensive, in other words, highly manual. It can be fragmented, lots of different systems operating slightly differently. Confidence in the data can vary. It's often retrospective, and we want to continue to press ourselves to really measure what matters and what's going to drive ultimately the definitions of quality that lead to the broader adoption and more consistent adoption of value-based payments. Quality is half of the value equation, and it is probably the half that stifles us as we try to move towards value-based payment. And so that vision requires this sort of snippet of what we recommended to the new administration for a scalable, sustainable digital quality infrastructure aimed at reducing waste and burden in the form of rework, duplicate infrastructure, duplicate efforts, or wasted effort, and really to connect what are traditionally linear and fragmented processes. And really, this gets to a concept that is talked about frequently called the learning health system that I want to speak a little bit more to. If you could go to the next slide. So there are a couple of things that I mean when I say that the current system can be fragmented and manual. And I wanted to use this sort of triangle framework to talk through some of those pieces and how these things work today, and how we believe and are starting to demonstrate that they can work in the future. So if you start at the top triangle, called clinical practice guidelines here, this is as simple as, what is quality care? What do we want people to do? What's the right thing to do? Now, it's a simple way to state it, but a very complex set of guidelines, best practices, recommendations that come out of that category. But that work today is often done by organizations like professional societies, or even some government or government-related organizations like the CDC, ARC, many others participate. But many of those organizations are really focused in that triangle, and that triangle alone, where that information about best practices is either published or distributed in what you would call a narrative format. In other words, human readable, but not machine readable, still requiring someone to interpret it, extrapolate on it often, and implement that in their own way, whether that's talking about a physician who's reading a paper or a best practice and thinking about how it applies to their practice, or whether that's a vendor, a health IT vendor who's trying to put in place things like decision support or care pathways. On the bottom left corner is the piece titled measurement. This is where we develop and disseminate the quality measures that are going to be used to determine how someone performed, and ultimately used to settle things like value-based incentives or value-based payments. This is the space that NCQA has traditionally focused on. It's a space where others play a role in both developing and publishing measures, or also soliciting measures. And that's a role that CMS and other parts of our federal government have played over time. And on the right-hand side, you see the triangle called data collection and reporting. And this is traditionally in the sort of old way of doing things, if you will, or in many ways the current way, this is where the implementation happens. This is where the now digitized clinical data and other sources of data for measurement, such as the claims that we have based a lot of traditional plan measures on, get actually collected and validated. The measures get run and reported on. And so you see a whole lot of organizations over here that look more like the vendor community or the plan, and in some cases now the delivery system community, who are trying to perform on these measures. They're trying to understand how they're performing. They're trying to perform better, and then ultimately they're having to report on that. But as I went through this, you'll notice not only are these domains traditionally separate, the work gets done differently, they're also done by different stakeholders traditionally. See the group of people, the group of organizations in the top triangle is often a little different and disconnected from the group in the bottom left. And then the group on the right is largely trying to implement and in many ways interpret, extrapolate, and operationalize content that's coming from the other two. This slide is really meant to illustrate for the Biden administration and others what a future might look like where those three separate domains and three separate groups of stakeholders can actually be brought together around a common set of approaches and infrastructure and tools. And that's the red triangle in the middle. This is a place where a lot of progress has been made recently, and that progress is in the standards community. So if you notice the red, the smaller red boxes within the triangles, there are standards that are either existing or evolving for how to express something like a clinical practice guideline or a clinical decision support rule. Standards for how to express digital quality measures in the bottom left, and standards for how to collect and share data, especially clinical data. Those standards are necessary but not sufficient to achieving a lot of the value that we talked about earlier with a better measurement system. It also requires tools, infrastructure, and approaches that can be common among the different parties that need to participate in quality and the quality related business processes such as value-based contracting. So when we made our recommendations to the Biden administration, we think there are multiple roles that the government can play in helping accelerate the development of some of these common approaches and infrastructure and standards, and also ways that they may be able to lead and create momentum and critical mass within that. So CMS, as the largest payer in the country, certainly has a lot of leverage to put forth the measurement and the programs and the standards that they want to use. They're also one player in the context in an ecosystem of many plans with many different measurements. And when you think about the provider side of this equation or the delivery system side, one of the challenges they have is lots of different programs, lots of different measures, all done slightly differently. How can CMS and the ecosystem think about common approaches that make it easier on providers to see how they're performing in an integrated view, in an integrated model that supports multiple plans, multiple programs, and multiple measures? We think CMS can play a role, and we've had a lot of conversations with CMS about that. There's also areas where there was benefit to the ecosystem for not just aligning to those standards, but perhaps sharing some of that infrastructure and tools. And that's a place where a lot of demonstration projects have been done. DaVinci is a great example of a place where standards are being implemented as demonstrations to show practical and deliver practical learnings about that. But how do we actually make that operational in the, for supporting quality infrastructure and quality processes writ large? We think that's a place where the new administration could make targeted investments as a convener, as a funding source, and ultimately as a stakeholder in helping advance some of that infrastructure, tools, and approaches to lay the groundwork, the middle triangle that allows these programs and this digital content, whether it's in the form of data or measures or guidelines and CDS, to be able to interact and basically interoperate. This is ultimately about creating an ecosystem of many-to-many relationships around quality, where that kind of quality insight and data can be shared easily. Just next slide. So that's where I will hand it off.
Thank you, Brad. Sorry, I had trouble getting off mute there. So we just wanted to really reinforce that we're at a moment when I think there are opportunities to collect patient experience data directly from patients closer to the point of care. And I think it's going to open up lots of possibilities at a moment, and I'll show you in a minute what's going on with CAHPS response rates. But I think we know that patients have a lot to tell us about the care that they're getting, and also about how they're feeling about the care, and how they're feeling after the care. So we think that this is going to be a golden age of really kind of creativity in terms of what the patient is going to be able to tell us. We know that this has been something that's been an issue in healthcare for a very long time. And I don't know how many of you have friends that are in healthcare who tell you that the system doesn't listen to them, and the people in the system don't listen to them. And we really, I think meeting people's expectations really requires a much more highly attuned system to what the patient is experiencing. So we think this is going to be an area of tremendous ferment and really potential opportunity for healthcare. Next slide, please. And it couldn't be coming any sooner, because you can see the response rates on CAHPS are going down pretty dramatically. And if we were researchers, we'd be saying these are inadequate response rates. But I think we're all surveyed a lot. The CAHPS survey is very long. I don't know if you've ever had the opportunity to do it. I did it both by mail and by phone myself. And it's quite comprehensive, to put a positive spin on it. And people are getting so many surveys, they're just tired of it. So we have to be more parsimonious about what we're asking, when we're asking it, and make sure it's something that the patient really wants you to know in order to do a better job with them. So that's going to be its own set of challenges. Next slide. This is a very busy slide, and I'm not going to read all of it, but this is from the Learning and Action Network, which has been trying to advance value-based payment. And I think I just want to put in a plug for why we need value-based payment, which is that it aligns the goals of the payer, the society, and the people that are delivering the care. Because if you are living within a budget, which if you're capitated, that's effectively what happens. You are living within a budget. And if you get more efficient, that's a really good thing for you. If you're in the world of fee-for-service, being more efficient actually makes you lose money. And so is it any wonder that our so heavily fee-for-service system results in the highest healthcare costs in the world by a factor of 2. And I think when you look at this, you can see that Medicare Advantage is really one of the most effective ways that, that we have value-based payment in this country. So there are other variants. There are kind of interesting models for specialty care. There's a lot of detail here, but in my view, when you get to the point when people, if they get more efficient and they do a better job, they get rewarded. That's really the point of value-based payment. So let me turn it over to Michael for the last slide.
Thank you, Peggy. So as Peggy referenced, we are very supportive of a strong and growing portfolio of value-based purchasing programs. We believe that these programs, the vast majority of which rely on HEDIS measures, can drive improvements in patient-centered care and provide a framework for accountability across levels of care, as Peggy said, not possible through a fee-for-service model. And further, this can be done with reduced burden on clinicians, teams, and health systems, and provide the data necessary to identify, improve, and reward equitable, high-quality care for Medicare beneficiaries and others. In this report, we identify opportunities for CMS to build upon the success to date of value-based purchasing programs. The high-level themes touch on program design, data and management strategies, the Medicare Advantage Star Ratings Program, patient experience measurement, the merit-based incentive payment system, or MIPS, and CMMI, Centers for Medicare and Medicaid Innovation Programs. I'm going to cover just a few key points we made. First at a high level, then I'll dive in a little bit deeper and wrap up and head to the next section. So value-based purchasing program design should be based on early input by a broad range of stakeholders to ensure buy-in. And while clinician level programs can help drive improvements, the program should motivate movement towards systems of care. A key aspect is trust. Trust is vital. These programs will only succeed when the data that informs them are validated and audited, the metrics of success are clear and meaningful for the entities measured, and performance is comparable. Attestation of compliance with these requirements or performance does not meet this standard, and I'll come back to that in a few minutes. We support the move to digital quality measures because it offers a path to dramatically bolster the accuracy and effectiveness of value-based payment programs. Digital measures can help wring out burden from the quality measurement system while introducing better, smarter measures, perhaps lowering the number of measures, but getting more information through the measures that we have, and leverage data generated in the course of providing care and from multiple digital sources, including, but not limited to, electronic health records, registries, health information exchanges, and case management systems, and as somebody asked in the questions, claims and encounter data, which are digital. And these improved measures could support more robust upside incentives and downside risk. So the Medicare Advantage Star Ratings Program is the most successful value-based purchasing program in healthcare. Why? It has a broad range of meaningful measures. All plans report the same measures. Measures have clear specifications. There is rigorous auditing, and this leads to meaningful benchmarking and comparisons that stakeholders can be confident are accurate and valid. We support the introduction of a more effective patient experience measurement set and better behavioral health measures, as well as reporting at the state or local level. And while we need and believe in outcome measures, we also need and believe in evidence-based process measures linked to those desired outcomes. We do not agree that a small set of measures focused only on outcomes, as has been recommended, can match a set that also includes well-designed evidence-based process measures and intermediate outcome measures that are collected with the least amount of burden possible using data generated in the course of providing good care. Key themes about the CMS merit-based incentive payment system that we included in the report are challenges with the number of measures, yet a limited number of relevant measures for some specialties, practices that are too small to yield valid results, an audit process that is inconsistent and limited, the complexity of attribution when patients in fee-for-service Medicare have multiple physicians, and the absence of broadly applicable advanced alternative payment models for specialty care clinicians. The section on CMMI includes similar concerns about assessing quality at a clinician and practice level and the need to consider movement towards systems level assessments. In addition, overlapping demonstrations make it difficult to differentiate how each affects clinical quality and cost, and how the continued reliance on attestation about alignment with the model design and expectations limits the ability to know whether a demonstration failed to achieve desired results because of its design or limited compliance with its requirements. We believe that these issues and others all support the need for continued movement towards value-based purchasing programs and the need to focus on a few fundamental pillars: integrity of data and performance assessment, coordination across the programs, moving towards systems of care, and collaboration with all relevant stakeholders to design and improve value-based purchasing programs. And again, welcome the opportunity to work with you and the new administration and stakeholders in the public and private sector on these and other issues in value-based purchasing. Thank you very much. And I believe this goes back to Frank.
Yes, thank you, Michael. Thank you, Peggy. Thank you, Brad. Thank you all for listening. We're not done, but appreciate your focus on the ideas section of the session here. We hope you enjoyed it. We point you to ncqa.org/qualityfuture, where you can read on the website all of the information that's in the memo, and you can also download the memo if you're inclined. And do feel free to reach out to any of us if you have any questions or issues with downloading. Now we'll move to what we're calling a digital fireside chat between Peggy O'Kane and Dan Mendelson, two people who have driven change in healthcare for a number of years and who have the scars to prove it. As noted earlier, Dan is the founder and former CEO of Avalere Health. He's an operating partner at Welsh Carson, a private equity firm focused on healthcare and technology investments, an adjunct professor at Georgetown University's McDonough School of Business, and a founding member of Guy Don Partners, an investment management group. Prior to founding Avalere in 2000, Dan served as Associate Director for Health at the Office of Management and Budget in the Clinton White House, where he was responsible for the full federal healthcare portfolio. As a reminder, we'll be fielding your questions, so use the Q&A button at the bottom of the screen to add your questions at any point during the conversation. Thank you, and let me hand over to Peggy.
Well, I want to hand it over to Dan because I think that, Dan is great he's a great sounding board, and he's had a chance to review this stuff, of course. But I'd just like him to react to, what we've been talking about. I did ask him if he would be willing to say something about the star ratings. I think many of you are well aware that the weighting of the clinical measures in the Medicare Advantage star ratings was cut pretty dramatically. And for those of us that have really seen the star ratings drive tremendous improvement in performance, we're concerned about this. So that would be my first question to Dan about, and of course, we've just gone through, we're not done either, but we've gone through a period where healthcare was very hard to deliver and people were appropriately concerned about quality measurement.
Yeah.
So one can understand that this, needs to be done at least in the short term, but anyway, so let me just ask Dan for his advice to the administration.
Yeah, look, I'll give a couple of reactions. First of all, thank you for having me here. And I have to say, of all the organizations in healthcare, NCQA, I think, does an amazingly effective job of balancing between the needs that we have to move towards quality-based systems and kind of the reality of what plans and providers can actually do. And it's very important to have that balance. And as a place where essentially there are kind of real and practical solutions coming out of an organization, NCQA is really very unique in that aspect. So I think it has a very, very important role to play, particularly in the context of change and a new administration. I'll say a couple of things about, first of all, the document and the remit of the Biden administration first, which is to say, COVID, of course, is the #1 priority. But then there are so many priorities that are very important and linked to COVID. Coverage is one. Not so much, the quality of coverage, which we've been talking about today, but just getting people coverage, which is a major aspect of ensuring that people have healthcare and elimination of disparities. And disparities, of course, is an independent goal as well, the elimination of disparities. And so, when thinking about how this administration navigates, there's so many issues and so many things that they have to do. They're going to have to prioritize, and they are, I think, effectively prioritizing Number one, dealing with COVID coverage as adjunct to the COVID relief bill, I think is a very nice example where, we're seeing deterioration of coverage levels in this country, which actually predated COVID. We all know that. It probably started when the individual mandate was repealed, but over the last 4 years, as investment in marketing for the exchanges and for Medicaid has kind of dwindled, and I think that it's fair to say that that's an important focus, making this insurance more accessible, less expensive to beneficiaries is a very, very important aspect of it. But every one of these changes is an opportunity for the quality agenda and for NCQA, because whenever you make health insurance less expensive, you can also start to work in quality incentives and work in more quality incentives and better quality incentives into the choices and make it clearer to individuals who are signing up for this insurance what it is exactly that they are buying. And so I think that in a lot of ways, the consumer protection agenda that the new administration will have works really well for NCQA because of the aspect of your vision, which is to make it more clear and with audited and validated results and kind of putting that into the hands of individuals. I think that this is going to be a great time for health plans, and expansion in Medicare Advantage is going to continue very rapidly. And the plans, of course, are going to underlie a lot of the Medicaid expansion and the exchange expansion as well. But it's very important to remember that this administration is also going to be very focused on accountability and health plan accountability. And I think that Democrats historically have been very concerned about making sure that appeals rights are strong and that plans are disclosing information to beneficiaries fully and that the quality agenda is progressing. And those three things, I think, really go hand in hand and are an important aspect and something where, again, NCQA is the practical place where the government can come to understand kind of how all of this should play out in the real world. Not that it's always most convenient for plans and for providers, but that it's necessary and again, achievable and validated. So those are some of my larger thoughts. To the question that you asked, I should answer the question that you asked about the clinical measures. Look, I understand the practical concerns that COVID is pushing on everyone, but those clinical measures are critically important, and you want to send the right incentives that the clinical measures are ultimately what we hold plans accountable for. And I don't think you stop the quality agenda. And in fact, I think you have to even put more into that and have more clinical measures so that care management is ultimately what the plans are accountable to, not necessarily just answering the telephones. And so, to me, it's a step in the wrong direction. And I think over time we have to correct for that and kind of bring back the importance and kind of the economics associated with these clinical measures for plans.
Thank you. I saw a question in the chat because I peeked at the chat about too many measures. And, I definitely agree with the idea of aligning measures. But I think that there's also an issue around workflow. And so I just wanted to speak to that for a few minutes, because I think, when I hear that there's a doctor that's like doing pajama hours, is what somebody called it the other day, that I was on a podcast, listening to a podcast, when doctors are going home from work and logging in their data, their quality data and so forth, that is not something that is sustainable, and it's certainly not going to motivate people to do better. But I think we need to think about the system of care that the practitioner is working in, and how much of it needs to be done by the doctor and how much of it can be done by the system or the practice. So I'm aware of medical groups where if you haven't had your mammogram, the person that checks you in will say to you, I see you need to have a mammogram. Can I make you an appointment today? So that's one less thing for the doctor to do. There are lots of things like that that can be, the work can be broken up, and we don't need to view every doctor as Marcus Welby that has to do everything, okay?
Yeah.
So I think that this is something that's being well understood by more advanced and larger systems, which tend to be, have more resources. But also as we move into the world of virtual care, I think there's going to be an opportunity to do a lot of things as a system that's enveloping and surrounding a patient and supporting that patient, that won't fall on the individual practitioner. And I look forward to that day. And, I just think I think that part of the reason we got very interested in this digitalization of quality measurement was we thought we have too many people measuring the same things in different ways.
Mm-hmm.
And this is a way of thinking about it. So alignment of measures is one piece of it. But I think that's one reason we're so excited about the digital future that Brad is talking about, is things can be counted multiple times.
I definitely agree. And look, I think, one thing I find interesting about the document that you put out as recommendations is it's a blend of things that can be accomplished in the short term and things that ultimately need to be accomplished in the longer term. And in the longer term, you can imagine a fully realized digital system that's really smooth and it's in the workflow and everything is kind of coming out of the workflow and you're getting race, ethnicity measures, and it's all kind of integrated. We're not there right now. And so I think that you also can't let that the reality hold back from accomplishing particularly some of these goals that the administration is putting out, so you got to collect the race ethnicity data. You have to be putting in the kinds of measures that are practical in the short term. You have to be getting the clinical data at the same time that we're kind of working towards this bigger vision of a fully digitized world, which we're not going to be there in the next 5 years, but yet we also have to be accomplishing these shorter term objectives.
Right. I think about managing against outcomes, and I think to me that is such a powerful construct. Like in Sweden, they have a system where people who have rheumatoid arthritis can go, and the video I saw was a person sitting down at a laptop and putting in their pain data for the day, and it's being integrated into with the drug data and so forth, and a plan of care is being developed for that person based on their symptoms. You think of what can be done for people with cancer, to titrate the chemotherapy, to make sure that they're taking their antiemetic drugs and so forth. You think of depression, and there's been fantastic work by Jürgen Unitzer about managing against depression symptoms and kind of having the system kind of be very vigilant about when there's no progress and what do you need to do to change the plan of care. So I think that we're coming to an age when care can be so much better and at such a much higher point. Yeah. And the digital picture that Brad laid out for you is part of the way that we're going to get there.
I agree.
And that's why we don't want to just say, let's just cut the number of measures and measure 3 things, and then we'll extrapolate from that to everything else. Okay.
Yeah.
So
no, I definitely agree. And I think that's one of the reasons why MA works so well for so many patients. It's because you have a more consistent digitized clinical environment, or at least more consistent than fee-for-service Medicare, which is, a complete mess. And I also look, if you think transnationally at the vaccine experience in Israel, for example,
right,
where it's compulsory that everyone in that country has to be registered with one of 4 health plans in the country. And it's a kind of a digitized community as a result of that, and how much further along they are, in part, for a lot of reasons, but in part because of the fact that they know who everybody is and everyone is registered with one of those plans, and they can access all people as a result of that, you know.
And
so
the
it's
plan called, I have friends over there, and the plan sent them a text and said,
Yeah.
you have an appointment, please let us know if you can
Right.
make that, or
right,
we'll
40%
reschedule
and
you.
40% of the population is vaccinated, and
Yeah.
they're starting
Yeah.
to work on the, so it's
So
different environment there.
Yeah, so I think we want to move on now to, we have 40 questions out there. Well, we're gonna not be able to answer them all, but we'll figure something out, Andy.
Let's
Are
get
you
to it,
gonna
Peggy.
play MC for the questions?
Happy to.
Uh-huh.
Many questions are about the slides. Yes, NCQA will distribute a link to the slides. You'll also get a link to the recording of the entire discussion today. We have several questions about big ideas. One listener points out, these ideas sound good, but how do these big ideas relate to other big ideas NCQA has been talking about recently? For example, electronic clinical data systems reporting and telehealth. So Peggy, why don't we start with you? The relationship between what we're talking about today and ECDS and telehealth.
Well, I think they're all part of the big picture. In fact, I'm going to turn it over to Brad, but let me just say a few things about telehealth. I think telehealth is the gateway to the virtual care system that we will all be experiencing. And it'll probably be a hybrid system. But I mean, we recently had John Halamka from the Mayo Clinic at our board meeting talking about hospital at home. And, you know, Mayo Clinic is actually experimenting with this and has been able to very effectively handle very complex patients at home with unbelievable 93 net promoter score or something was what he was talking about on average. I don't have enough time really to talk much about telehealth, but I think it's kind of maybe it's like the railroad tracks. I don't know what the metaphor is, but it is going to take us into the digital future, I think. And yes, we have a lot of things to straighten out. Before that, we have broadband issues. We have literacy issues, computer literacy issues. Although the elderly, I think, surprised a lot of people during the real shutdown because they had been on Zoom with their grandkids and they know how to use their computers. So,
You know, Peggy, there's a related question that in there that asks whether NCQA is advocating for more payment to providers or plans for digitization. And, you know, I kind of want to make a point from my perspective, of my view, that it is very important for the administration to fund more of this work and at the same time to have requirements. And, you know, to me, those two things kind of go hand in hand because it's standards, funding, and requirements all need to be pushed forward. And the more aggressively we push all three of those forward, the better off everyone's going to be. And I think the closer we get to the realization of this vision that you're articulating.
yeah, I mean, I think it's an interesting issue. And in our telehealth task force, we had a lot of discussion about this. And for me, the full flowering of telehealth can only occur in a value-based payment environment. Again, if you're going to lose money by doing something in a more efficient way, then you're not going to do it, right? And you're going to be asking for an extra this or that for doing it by telehealth and so forth. I mean, you can see a lot of payers really backing away. And I think even MedPAC is very worried about potential abuses of telehealth. So, you know, everything has both an upside and a downside. But I think the way to think about it is you're living within a budget. How are you going to get the best value? And how are you going to use those telehealth tools?
Could I jump in and maybe
Yeah.
comment quickly, Dan, on the point you were making? I think there's an intersection with telehealth and what Dan was talking about, but I think, Dan, your comments were maybe even larger than telehealth, but just about the digital quality infrastructure and the comment or the question about how the administration can fund it. I think what happened with meaningful use subsidies is an example. It's not the only way to fund or create incentives for this kind of stuff. To Peggy's point, thinking about the aggregate cost and the incentive model that we drive is really important. And one of the points that we've made to the administration in some recent conversations, specifically as it relates to measurement, is a change in the way that they think about funding the measurement enterprise. In other words, if you think about what happens today, frequently they will fund a grant or a project-based work to do something like measure development. And then a measure or a set of measures get kind of tossed out to the public to figure out how to implement that, right? And what the requirements are that go along with it. A lot of the burden for not just figuring out how to implement that measure and is the data available and how hard is it to get, but also a lot of the effort or a lot of the dollar cost falls on our delivery systems and our payers to either hire a vendor or hire armies of chart abstractors or administrative support to go implement that. And that's a piece of the cost of the current system that it's not clear is always seen holistically. And that the administration thinks about, how are they funding that piece of the current operation, or if they want it to evolve and become digital, how are they going to fund that? So we've had conversations about reframing from funding measure development to funding measurement, right, as a system, including the validation and the data collection and the producing of results and sharing of results. That is a place that we think the administration should explore, however they choose to fund it.
Mm-hmm. You know, there's one other aspect of this that has not come up in the discussion thus far, which is what is the role of the patient in all of this? And does the patient, which is my view, the patient really does own her or his own data. And to me, ownership also means you can access it, because it's not really, you can't really think of something that you technically own, but you can never get it. And I do think that this administration is going to be focused on that aspect of things as well. So that, you know, plans and providers would be well served to start thinking about that now, because consumers should be able to get their own data and should be able to get their own experience data and quality data as well. So those are all pieces of the puzzle.
Thank you.
Dan, I'm glad you brought up the patient. We have several questions from patient perspectives. I'd like to bundle some of these questions for the sake of time. One patient-oriented question is, how do patient-reported outcomes factor into the new landscape? And second, patient-related questions, what would you say to a patient who is worried that a value-based system creates incentives to minimize care? Peggy, would you like to start with either of those patient-oriented questions?
Yeah, I'll start with the second one. You know, there's no perfect payment system, but I think I think it's Don Berwick said every system is perfectly designed to produce the results that it produces. And in fact, our fee-for-service system has done a great job in promoting lots of waste, lots of more complex care, lots of sacrifice of primary care to being able to do a good job and thrive because they don't get paid enough. There's just a lot of things with the current payment system that are not good. But there is no perfect payment system. And in value-based payment, you do have to worry about like appropriate care being withheld, or, you know, something being done on the cheap when it should have been done in a more maybe expensive way. And so that's part of the reason why you have to have quality measurement. Mm-hmm. So, you know, it's a complicated world. There is no way to just pay everybody and then say, go ahead, go off and do good. We trust you.
And I just want to jump in, I know we're at time, but to add to Peggy, the patient-reported outcome measures is a topic of great interest for NCQA, especially for assessing people with multiple comorbidities and complexities where a specific measure or specific guideline wouldn't hold, but that's a measure that matters, something that matters to the person, and measuring against that. How you use that in an accountability framework is a separate question, but as a metric to see whether you're doing better and improving care for an individual, we really have a lot of research and interest in that topic. So thank you for asking the question.
Thank you, Michael. You are right. We are at the top of the hour. So I'd like to wrap up by reinforcing something that Michael mentioned, and that is HEDIS public comment opens this Thursday and runs for a month. We greatly urge everyone interested in these issues to take a look at public comment. There are important topics on the table that we know you'll want to comment on. So again, please do be part of public comment, open for 1 month, starting this Thursday.
So Andy, there were a lot of good questions in the Q&A. Is there some way to think about, I don't think anybody wants to read the answers to 51 questions, but what do you suggest that we do about that?
We can handle the questions we didn't get to in a lot of ways. One option is to develop them in or answer them in a blog series. We can also think of other ways to distribute answers to particular questions. People who showed up for this webinar, we know who you are. So we can follow up with you by email. But Peggy, I agree. There are many thoughtful questions that we haven't had time to get to, and we can answer them through different channels.
And Andy, we have a Future of HEDIS webinar later this month that perhaps we can address some of these questions.
That's true. That Future of HEDIS event that Michael referenced is Wednesday, the 24th of February. So 2 big dates coming up, public comment starting this Thursday, the 11th, and then a deep dive into HEDIS, the future of HEDIS, on Wednesday, the 24th. We are at time. Thank you all for being here. Have a good day.
Thank you all.